This is Abhijit Barai. In this video, we are going to talk about the interpretation of an ECG. So I'm going to show you how to interpret an ECG within 20 seconds. So it takes about 20 to 30 seconds to read the ECG in a proper way. If you do that again and again, then you will be able to detect most of the abnormalities of the ECG, and that will help you in the management of the patient. So please follow the steps as they have mentioned here. And usually at the end of the session, you will be more confident in reading, interpreting, and management of the patients with an ECG. So let's have a look at one ECG of a patient that we have seen recently. So this is a 12-lead ECG, and as you can see that there are 6 limb leads. So this is lead 1, lead 2, lead 3. This is AVR, this is AVL, this is AVF. And then we have got 6 chest leads. This is V1, V2 here, V3, V4, V5, and V6. At the bottom, there is this rhythm strip, which can be sometimes useful, especially if the patient has got irregular rhythm or some rhythm problem. So in a normal ECG, so ECG is basically the graphical representation of the electrical activity of the heart. And normally, when you say lead, it is not the electrode which is connected to the body. Lead means the view of the heart from a specific direction. So for example, if we talk about lead AVF, it means what is happening to the undersurface of the heart. When I talk about lead 1 or V6, it means what is happening to the left surface of the heart. Normally, there are 6 limb leads as I have shown you, and also there are 6 chest leads. If required, we can do some other leads, for example, V4R, if we are concerned about the right side of the heart. If we want to see what is happening to the back of the heart, to the posterior aspect, then we can do V7, V8, and V9. If we want to see what is happening to the atria, like in case of atrial fibrillation, atrial flutter, or in case of the ventricular tachycardia or VT, we can do a special lead which is called the Lewis leads. So if you want, you can do a lot of different leads, but normally in a normal ECG, we look at 12 leads, 6 chest leads and 6 limb leads. So in this video, we are going to talk about mostly this 12 lead ECG, but there are some subsequent other videos where we can talk about V4R, we can talk about V7 to V9, and also in Lewis leads. So let's see what happens to the heart itself. So this is let's get some oriented with the heart. So this is the superior vena cava. Here there is the inferior vena cava. This is the right atrium, and then this is the right ventricle. This is the atrioventricular valve on the right side. Tricuspid valve is the name. Then there is the interatrial septum here, and then there is the interventricular septum. This is the left atrium here, and these are the small pulmonary veins. The left atrium opens into the left ventricle, and this is the mitral valve here. From the left ventricle, the blood goes to the ascending aorta through the aortic valve. Now, if we look at the conduction system, the pacemaker is the SA node, which is lying here, usually at the upper part of the right atrium. That generates the cardiac impulse at the fastest rate. That is why it's the pacemaker. Now, there are usually 3 interatrial pathways. One is here, one is here, one is here, and then there is the atrioventricular node. From the atrioventricular node, we have got the atrioventricular bundle or bundle of his. We have got the right bundle branch here, and then there is a left bundle branch. The left bundle branch again divides into the anterior fascicle and the posterior fascicle. And then we have got the Purkinje fibers and then the ventricular muscles. So let's see what happens when the SA node starts firing. All right, so this is what happens. So the cardiac impulse is generated in the SA node. It goes to the atrioventricular node. There is a bit of increased refractory period in the AV node. That is why there is a bit of a delay. So when the cardiac impulse is generated in the SA node, we get the P wave. So the ECG machine amplifies the electricity several folds so that we can get a good graph here. So the P wave that represents the electrical activity that is happening in the atria. So that is the P wave. Then there is a bit of delay in the AV node, as you can see here. Because of the delay in the AV node, there is a bit of PR interval. The PR interval is from beginning of P wave to the beginning of QRS complex, and the From the end of POF to the beginning of QRS complex, that is called the PR segment. So PR interval and PR segment, they are not the same, they are different. When the cardiac impulse passes through the normal conduction system, we get the QRS complex. Normally, in a lead, you will never see Q, R, and S, all three together. Either you will see Q wave and R wave, or you will see R wave and S wave. As the cardiac impulse goes to the ventricles, so there is repolarization of the ventricles after the depolarization, and that is represented by the T wave. And it goes on and on and on, usually between 60 to 90 times every minute. As we speak, that is what happens. Now, this is the electrical activity, remember. The electrical activity will be followed by the mechanical activity, and that is when the ventricles contract, the atria contract. Right. So every time I look at the ECG, I use the little watch that I have generated. So this is my little stopwatch. So there are a few steps that we can use. So the first thing we look at is the rate. There are different ways of calculating the rate. For example, if the QRS complexes are regular, you can count the number of the largest square in the RR interval, and then divide 300 divided by the RR interval as the number of largest square, that is the rate. However, if the QRS complexes are irregular, for example, in atrial fibrillation or atrial flutter with variable blocks, look at the rhythm strip, count the number of the QRS complexes and multiply it by 6. That will give you some idea of the rate. The rate is important. It gives us some idea whether the heart is going too slow, too fast, or it is normal. Once you're happy with the rate, then look at the rhythm. Is there any atrioventricular dissociation? Is every P wave followed by a QRS complex? If there is any happy marriage between the P wave and the QRS complex, that is sinus rhythm. Once you are happy with the rhythm, whether it is regular, irregular, sinus rhythm or not, then let's look at the axis. For axis, look at the lead 1 and AVF. Normal axis is -30 to +90. If there is left axis deviation, there is prominent S wave in prominent S wave in AVF. However, if there is right axis deviation, there is prominent S wave in lead 1. If there is a prominent S wave in both lead 1 and AVF, there is northwestern axis, which usually is found in case of the VT. So once you're happy with the rate, rhythm, and axis, then you look at the PR interval. As I mentioned earlier, the PR interval and PR segment, they are not the same. Normal PR interval is 120 to 200 milliseconds. If it is prolonged, that can be because of the atrioventricular block. Patient might have taken some drugs like beta blocker or some calcium channel blocker, maybe digoxin, or there may be some overdose with some other goodies. PR segment is important because if the PR segment is depressed with some ST elevation, patient can have pericarditis or myocarditis. It can also happen in case of myocardial infarction. Now, the gold mine in the ECG is the QRS complex. So that is the depolarization in the ventricles. So always look at the whites of the QRS complex. Is there any bundle branch block like the right bundle branch block or left bundle branch block? And that will help us in getting what is happening to the ventricle, right? Once you are happy with the QRS complex, then you look at the ST segment. Again, ST segment is very important. In the ECG that I have shown you, ST segment is the main attraction. So ST segment should be compared with the TP segment. The TP segment is the isoelectric line. If the ST segment is depressed, it can be because of myocardial ischemia or some electrolyte abnormality. If the ST segment is elevated, there are a lot of different reasons. It can be pericarditis, myocarditis, it can be STEMI, it can be hyperkalemia, it can be Takotsubo-Brugada syndrome, it can be left ventricular hypertrophy, it can be pacing rhythm that can give you ST elevation, it can be early depolarization. So there are about 20 different conditions where the ST segment can be elevated. So we need to keep an eye on it and look at the big picture, what is happening to the patient. So after you're happy with those 6 steps, then look at the QTC. Please don't forget to look at the QTC. It will give you some idea exactly what is happening with the patient, but also it will help us in giving the drugs. For example, if the patient has got prolonged QTC and if we give some relatively safer drugs like erythromycin or hydroxychloroquine or even ondansetron, that can actually cause torsion de points. That patient can have polymorphic VT. So that can be a life-threatening catastrophe. So look at the QTC every time you look at the ECG. Now, AVR is considered as the most neglected lead. So please look at the AVR. It will give you some ideas what is happening to the axis. It will also give you some idea about some of the conditions like VT. Vericay criteria is based solely on AVR. If you look at the ST elevation in AVR more than 2 millimeter, that can be a left main coronary artery disease. Also, there are some weird and wonderful things like if the patient has got poor R wave progression. If you look at the lead V3 and if the R wave is less than 3 millimeter, that can be a myocardial ischemia. So usually when you look at the ECG, when you read the ECG, we look at these steps. So usually there are 1, 2, 3, 4, 5, 6, 7, 8 steps. So usually these are the 8 steps which will give us some rough idea. But the machine can actually get most of this information. What is important and why a doctor is required is the last bit, which is the synthesis. So don't read the ECG itself alone. Look at the patient. How old is the patient? What are the risk factors? Is it a life-threatening condition? Does we need to give some medicine like amiodarone? Or is amiodarone actually going to kill the patient? If the patient has got hyperkalemia or tricyclic antidepressant overdose, and if we give amiodarone, that can cause harm to the patient rather than any benefit. Does the patient need to go to a cath lab? Does the patient need to be shocked right now to save the life? So that is the decision making. That is when we need a human brain. We need a doctor, right? So any medical student or even the ECG machine can give you those first 8 steps: rate, rhythm, axis, peer interval and segment, QRS complex, ST segment, QTC, AVR. So as a doctor, we are needed for the last step, which is the synthesis, and we can save the life by doing those steps. So let's come back to the first ECG that I have shown you, and we will do it together. So this is the 12-lead ECG, and we have a rhythm strip as well. So let's do it together. So the first thing we look at is the rate. And what is the rate in this patient's ECG? So we can see the QRS complex are pretty regular. And if we look at the RR interval, that is 1, 2, 3, almost 4. So probably the rate is about 70 beats per minute, and it's pretty regular. So after the rate, once we are happy with that, then let's look at the rhythm. So as you can see here, there is a P wave followed by QRS complex, P wave followed by QRS complex, P wave followed by QRS complex. So every P wave is followed by a QRS complex. So there is a bit of happy marriage between the P wave and a QRS complex. So this is a sinus rhythm, no doubt about that. Okay, and it is regular. Then look at the axis. So look at the lead 1, and there is a prominent R wave here, and there is a prominent R wave in AVF. So this is a normal axis. So probably this patient's axis is around 45 degrees. I'll show you how to do the axis, how to calculate the axis in a different video. After that, we will look at the peer interval, and we have already looked at the P wave followed by QRS complex. So if we look at the peer interval, that is about maybe 4 small square, which is about 160 milliseconds. That is pretty normal. And if we look at the peer interval in every QRS complexes, as before the QRS complex, it's pretty regular. There is no second degree atrioventricular block like Mobis type 1 blocks. And the peer interval also is isoelectric. If we look at the TP segment and peer interval, pretty isoelectric. Look at the QRS complex. The QRS complex are pretty narrow QRS complex, and the width of the QRS complex, that will be probably about 3 smaller square. Probably actually, if we look at from here, so probably about 2 smaller square, which is about 80 milliseconds, which is fine. It's normal. There is no right bundle branch block or left bundle branch block. So, and as I mentioned earlier, that in any ECG, you will never see RS, QRS together. You will see either an R wave and S wave, or there is a small Q wave and an R wave. So in lead lead 3, there is a small Q wave and R wave, but Q, R, S will never be found together. Look at the ST segment, and that is the main attraction in this particular ECG. So let's do it together. So this is the lead 2, where there is ST elevation 2 millimeter. In lead 3, there is ST elevation 3 millimeter, and there is AVF, with where there is some ST elevation as well. You might argue that there is some ST elevation in V5 and V6 as well, and definitely there is ST depression in AVL. So usually if there is an ST depression in AVL, that is a telltale sign that this patient has got an inferior STEMI or myocardial infarction. So in this particular patient, the ST elevation is greater in lead 3 than in lead 2. So this is a right ventricular STEMI. And also there may be some subtle ST depression in V2, which supports this diagnosis that this is a right ventricular STEMI. This is the type of the ECG where we need V4R to see what is happening to the right surface of the heart. Right, so we have got some issue with this patient, right? I have not finished yet, so let's complete it. So look at the QTC. So if you look at from the beginning of QRS complex to the end of the T wave, so that is about 5, 6, and maybe 7, 8, 9. So 9 multiplied by 4, 360 millisecond, which is pretty normal. So usually the QTC is 350 to 450 millisecond. Usually we don't get very concerned if it is below 500. If the QTC is more than 500, they are at higher risk of the torsa de pointes, right? So in this particular patient, I would say QTC is normal. AVR, please don't forget AVR. So in this ECG, the AVR is pretty much isoelectric when we compare with the TP segment. There is some ST depression and T wave inversion in AVR, which is normal. All right. So now the most important part is the synthesis. So we will consider exactly what is happening to the patient, not the ECG alone. So as I've already mentioned, if we look at the rate, rhythm, axis, PR interval, QRS complex, ST segment, QTC, AVR, my impression is that this patient has got an inferior STEMI, probably right ventricular STEMI. So I will have an urgent cardiology consult. Patient needs to go to the cath lab for an urgent PCI. If the PCI facility is not available, this patient fulfills the criteria for thrombolysis. So we'll give aspirin, 300 milligram, clopidogrel, 300 milligram. You will give fentanyl, maybe 40 to 50 microgram to control the pain. We'll give some antiemetics. We can give some normal saline if the blood pressure is low or lowish, maybe 250 ml of normal saline, IV stat. Please, please, please do not give GTN in this patient because this patient has got right ventricular STEMI, and if we give GTN, blood pressure will drop, might even develop cardiogenic shock. Depending on the hospital protocol, after consultation with the cardiologist, we might give some heparin as well, maybe 5,000 unit of heparin IV. So as I mentioned, the definitive care is reperfusion therapy. I would suggest PCI urgently by activation of the cath lab, but if that is not available, we'll at least do thrombolysis. So that is my synthesis about this patient. The complications that I am thinking of at this moment is that all the complications of STEMI, patient can develop dysarrhythmia, maybe left ventricular aneurysm can develop, they can develop mitral valve prolapse, they can develop cardiogenic shock, cardiac arrest. So all the nasty things can happen in this patient. Right, so let's do a quick summary of this. So first of all, when we look at the ECG, make sure that this is the right patient. Look at the rate. Once you are happy with the rate, then we look at the rhythm. So make sure that the rhythm is regular or irregular. Is there a sinus rhythm? And after we're happy with the rhythm, we look at the axis. Is it normal axis between -30 to +90, or it is a right axis deviation or left axis deviation? Once we are happy with the axis, look at the PR interval, PR segment, and then look at the QRS complex, which can be sometimes a gold mine in the ECG interpretation. Once we are happy with the QRS complex, look at the ST segment. Is it isoelectric? Is it elevated? Is it depressed? And once you are happy with the ST segment, then always look at the QTC. It can give you some information about the patient condition, but also it will guide us in the management of the patient. For example, prolonged QTC, do not give any ondansetron. AVR, which is neglected lead, and please don't forget AVR. And after you are happy with that, with the basis of those 8 steps, then get some information about the management of this patient, do the risk assessment, and take some appropriate steps in the management of the patient. So every time you look at the ECG, if you follow those 9 steps, you will be able to not only diagnose, but also manage and have some good idea about the possible complications, and we can avoid those complications. So these are some very good articles in Up to Date. We use Hampton's book quite a lot. That is the ECG Made Easy, but also there are some lot of other resources available. So over the next few videos, we'll talk about the individual cases. We'll talk about the atrioventricular blocks. We'll talk about STEMI. We'll talk about the ventricular tachycardia. We'll show you how to calculate the axis, how to interpret the ST segment, how to calculate the QTC, and there are hundreds of ECGs we can talk about. Over the next few weeks or few months, we'll go through those ECGs individually, and hopefully we'll have a very good interpretation capabilities by following these steps. If you have got any further questions, you can write below or just get in touch. All right. Thank you very much for your time, and I'll see you soon. Bye for now.